Well, welcome, Vizient members. We really appreciate the opportunity here to speak to you today, Signet Health, about the continued need for acute physical rehab services and the staffing challenges we have. I'm Pat Doyle, Executive VP, Chief Development Officer for the company, responsible nationally for working with the different member hospitals for our services. We have Paul Pizzo on the line, Vice President of Operations, occupational therapist by background, years of experience both in hospitals, freestanding rehab facilities, who will talk today, and Ann Belvin, our VP of Talent Engagement, who's involved with all the recruitment and staffing challenges the healthcare industry is seeing today. Next. A little about Signet Health. We're a 23-year-old family-owned company. There's the Browder family. I believe it's gotten larger since this picture, but all of us feel blessed to work for Signet Health and the Browders. I personally have known Jerry, the founder, for about 35 years. And we're based in Denton, Texas, or North Richland Hills, Texas, a suburb of Dallas. We're privately held. We work with about 70 hospitals in 25 states, and that's between both behavioral health and acute physical rehab. We are the sole strategic business partner with Vizient and for both these service lines, so we can offer both these very needed service lines that are pretty much in the post-acute arena. And one of the things that have attracted most of us here is Signet tries to do the right thing. We're not perfect, but we all have high confidence that the Browder families will always do the right thing for our host hospitals and our clients. And just a small window, we have never paid even a settlement with any governmental agency in 23 years. And I don't think any of the other providers in this space can say that. Next. Paul?
Oh, thank you, Pat. Yes, let's talk a little bit about the need of acute rehabilitation in our world today, especially when we look at coming out of a pandemic like the COVID-19 pandemic. Rehabilitation needs are definitely still out there. We have patients who've been hospitalized with COVID-19 and demonstrate some form of debility after their hospitalization. We're also seeing the effects now of what's called long COVID, where you're seeing cognitive and other effects that are continuing to affect someone who has had COVID-19, especially in the more severe cases. So you have patients that have been receiving ICU level of care, and they may develop some ICU-related weaknesses, which damages the muscles and nerves, which means that the patient is really going to be needing additional help after their COVID recovery and during that COVID recovery from acute rehabilitation services. Patients can also be affected cognitively with delirium, with some patients, or those long haulers like I was speaking about. And we've also, we look at different ways that we can improvise or use acute rehabilitation techniques different ways. And so we also look at our virtual outpatient rehabilitation abilities and telehealth as well. Next.
So COVID clearly is creating a demand for more acute physical rehab. A couple of the other dynamics we're all familiar with: an aging society. And what we see on these programs on the inpatient side is what I'm going to talk about today, is that 30 to 60% of the clients that we service are traditional Medicare. And then when you add Medicare Advantage into that, which is a growing payer cohort, overall, we're seeing about 60% of payers on inpatient acute rehab being either Medicare or Medicare Advantage. So it's a growing need. CFOs are able to quantify financially pretty easily when you know 60% of your payment is coming from just those two categories. Something that's different, and Signet also is involved in behavioral health. Behavioral health, geropsychiatry, 80% plus of the referrals are external. Adult psychiatry, 50% plus are external. On inpatient acute rehab, only 20 to 30% are typically external admissions. So what's very important, and Paul's going to talk about this, he'll break it down even further on the diagnosis of these patients. 70% of the admissions coming to an inpatient acute rehab unit are already within your hospital. These are patients you have today. And if you look at bullet 3, what's happening is they're going elsewhere. They're going to freestanding rehab facilities, which only represent roughly 20% of the rehab providers in the United States. There's over 1,000 inpatient acute rehab units in hospitals, and there's probably 200 to 300 rehab facilities, hospitals, but they're treating almost half of all the patients in the United States, and it's getting even more that way. Just for Florida, an example, 15 new rehab hospitals now. I literally heard of a 16th today on a phone call. Are opening new rehab programs in Florida, and many of the acute med-surg hospitals are just sitting by. And these rehab facilities are going to care for those patients that we think could be more easily and better cared for in the host hospital right down the hallway or on a different floor. The other market dynamic, LTACs, and there's a lot of long-term acute care facilities out there. Some are owned by rehab companies. They now can offer inpatient acute rehab, ARUs. So they are going to compete with you. And the market, you can see on the last bullet, 1 out of every 5 med-surg patients being discharged need post-acute. Next slide.
So let's talk about what we do in the acute rehabilitation unit. Within this unit, the Medicare beneficiaries treated in your inpatient rehab facilities or your ARUs must meet a very stringent admission criteria to ensure that that level of care is necessary for acute rehabilitation. 60% of all of your cases must have one of Medicare's qualifying conditions, and Medicare auditors will ensure that patients satisfy very strict guidelines. The remaining 40% do not have to be one of those qualifying conditions, but must meet all of the other criteria. So when we're talking about criteria, we're talking about certain diagnostic groupings of the patients, and so that you have a very well-defined case for rehabilitation based on diagnostic groups, but then you also have patients who will meet criteria that may not have that diagnostic group, and that would be your 40%. So here are some of the admission requirements that we would have. The most common diagnostic group that you would see would be for a stroke patient, neuro patient, or complex lower extremity fractures. Those would comprise 10% for your femur fracture. Neurological would be 13.6%, and strokes are 22% of that. So when we talked about 60% of patients admitted must be in that CMS 13 category, or that 13 indicator group, these would be the primary ones: stroke, fractured of a femur, complex fractures, as well as those neurological diagnosis. An individual without that rehab diagnosis who meets all the admission criteria or medical necessity, participation, and benefit, 40% of those patients are still allowed, and they would go into the 40% category. All patients in your acute rehab unit must receive at least 3 hours of therapy, 5 days out of 7, beginning on the day of admission. And they also must require 24-hour nursing care and have criteria. Part of the criteria specifies that nursing care must be needed throughout their stay as well.
And one of the things Signet will do when we work with a hospital operationally, we keep track daily. We expect our people that are there to know exactly what the percent compliance is, so that if we know you're at 70% and you have a person that medically meets that non-CMS 13 to be admitted, you can take that patient. So I've been on units where I asked the director, they didn't know what the compliance rate was that day. And you're missing out on caring for some patients.
All right, so let's talk about some of the other areas within rehab that are specific to the acute rehab unit. You will see a discharge rate to community, which is the ideal discharge placement for a patient coming to acute rehab. You want them to be able to go back home into a community setting. And the national discharge rate for that would be 76%. We have an average age of patients of 75. Length of stay. The average length of stay in an acute rehab unit is right around 13 days. And then the CMI, or the case mix index, the grouping of that patient, the average would be about a 1.4. This is something that we would look at with any of our hospitals that may have an existing rehabilitation unit looking for some enhancement, to look at where is that CMI at, and is it meeting or beating that that national average? Because based on the way that everyone works to code the patient correctly, we can ensure that the facility is receiving payment for what's actually taking place in the services they're providing. We also want to have, we want to make sure that we're working with the hospitals to have potentially avoidable rehospitalizations during that inpatient stay on the rehab unit at 2.6%, and compared to a 10.9% in SNF. We're all worried about rehospitalizations. We want to make sure that we keep that percentage down and that we take care of the patient in the setting that we have them in now. The data gathered by the AMRPA showed clinically comparable patients who stayed at an inpatient rehab hospital instead of a skilled nursing facility on average. They remained home nearly 2 months longer, had 5% fewer emergency visits per year, returned home 2 weeks earlier. Important point there. Patients that are being seen in an inpatient rehabilitation unit or hospital, they're getting home quicker than they are from other settings, such as a skilled nursing setting. These patients also showed an 8% lower mortality rate.
Yeah, Paul and I were on a call Monday, in fact, where the hospital has a program. They're reaching out to us to try to make it work better, enhance it. And their CMI was about 1.1. Now, the CFO was on the call, and there were plenty of things mentioned clinically that we'll look at. But just looking that his CMI was 30% or 0.3 less on an average payment that is about $22,000 for Medicare, they're being underpaid by about $6,000 compared to the national average. So that's something they're clearly interested in. The last thing I'll point out about the bottom, many times our medical director or physiatrist will have to go peer-to-peer, and it's usually with another physician, but not a physiatrist, for managed care, and explain why these clients need to get the care on inpatient acute. And that bottom sums it up pretty nicely versus the subacute, which can be less.
Within a rehab unit that Signet Health is managing, we look at recruiting of staff members, and specifically having some folks on our staff through Signet. But we're looking for a director of rehabilitation. This will be your person who is the day-to-day operator of that rehabilitation unit. They will be responsible for supervising employees on the unit, and also working directly with your physiatrist in order to make sure that you have the appropriate patients coming onto your unit, and receiving those patients as quickly as possible from the acute floor. We also look at needing a physiatrist for a rehab unit. A physician that is specifically trained and has experience in the world of physical rehabilitation. And so as a part of our service, we recruit and bring on that physiatrist for the program. We also look for a PPS coordinator, who is a vitally important person who collects the data from the medical record and it puts it into what's called the IRF-PI, which is the data collection form that is used by CMS to collect data both for reimbursement and for quality program information. So that PPS coordinator is going to be a vital person on that unit who is going to be collecting and putting all of that together and making sure that patient has all the right information in so that the reimbursement is correct for that patient. We also recruit for clinical liaison for a program. This would be someone who is out there taking a look at the patients that looking at criteria, making sure they meet criteria, and also working with outside referral sources. So looking at that outside business and talking to the stakeholders from other hospitals or facilities that would have patients that could be referred to us and working with them. We also will assist with the recruitment of nurses and therapists. Others would also include case management or a social worker for the unit. Anything that's needed from an employee standpoint, we can certainly assist with that recruitment.
And Ann, you may want to mention how even though some of these are not on our payroll, you have rolled up your sleeves, your department, to help out, right?
That's right. Thank you.
Okay, next slide, Ann.
Yes, as Pat had mentioned, I am the Vice President of Talent Engagement, and my job is to find great employees all over the country for our programs, and we can assist our clients as they need it. For different things in our recruitment process, we do customize our recruitment strategies. We based on the geographic location or the particular client. We try to write compelling job descriptions to maximize the number of candidates that do apply. We do normal things like we post on our job boards, social media sites, Indeed, LinkedIn, Glassdoor, healthcare sites. We also network with universities, professional trade associations. We execute e-blasts through emails for folks in our applicant tracking system or through members of an association or university. We also do catchy direct mail pieces to our applicants. We pursue candidates in similar positions. In all of our areas and all of our marketplaces, we know who our competition is, and we reach that active but also the passive job seeker. During the interview process, we screen the candidates and we treat candidates to impress. We want them, regardless of whether we're hiring them or our client, we want them to come away with a great applicant experience. During the interview process, we look for transferable skills. Can things be taught? Is there an area that we can help them with if they're lacking? And then the last stage of the interview process is execution of the hire, is really closing the deal. Next, Pat.
Yeah, I was on a call totally unrelated to this webinar just a few minutes before, and we hired nurses at a hospital, a rural hospital in the Midwest. And the hospital, the nurses were on their payroll. They had 2 applicants before they turned it over to us. And in 90 days, Ann's team got 31 applicants, and we filled the place, filled the nursing positions, which enabled them to leave where they were during COVID and get back a little more towards normal on our Signet managed program.
One of the things that I'm sure everyone has felt in the last few years is the high cost of hiring someone new into a position, and then all the expenses of the training and everything that is necessary and required in order to bring someone on new. And so I thought I'd spend a little bit of time talking about how do we retain those individuals, make sure that we keep these great people that we're hiring, that everyone's worked so hard to bring into the organization. How do we keep them? And so based on some of this is based on my experiences working with therapists and nurses for close to 30 years now, and also being involved in quite a few employee engagement surveys of what is meaningful to them in staying at a job. One of the top things that always comes up is communication. Everyone wants to receive good communication that's purposeful and meaningful for their job. And it's an area that everyone can really improve upon in making sure that we have good communication going out to the employees. Advancement with a growing company is a very important piece as well. if someone is doing doing such a great job with where they're at, and they'd like to increase responsibility, increase their income as well. We want them to look within the hospital that they're working in or the company that they're working with, such as Signet Health, and see that there are plenty of ways to advance and to build their skills and grow in not only in their skill level, but also in the positions that they may be able to apply for and work in. Another area of retention is flexibility in the position. Everyone would probably agree, after we've had a lot of people home officing, not healthcare workers. We didn't get to home office, and I'll speak from my own experiences. I was in a hospital every single day throughout the entire COVID pandemic, and still currently I'm weekly in hospitals. But what other flexibility can we offer within the healthcare jobs? And so that's an area to make sure that we look at and see how we can personalize any flexibility for employees. We want to see mentoring programs. Mentoring programs are fantastic to make sure that someone has another person to talk with and work with. Desirable benefits, education, and internal training, of course, very important. I believe I'll have some time to speak a little bit more on some of the training that we can offer. But this is an area that I see employees very positively react to specialized education for the type of job that they're in, not just that general orientation, but it's more specific to their job and what they'll be doing. It's also important in order to retain staff to have values within your company. Missions and the ethics of the company are important, and being part of a national network, of course, is very important. Here's some more specifics about retention. Allied health student programs. This is something that I feel is an excellent way to retain experienced staff. If you have a student program where your experienced therapists or nurses are able to be the teacher, the influencer, the mentor for someone that is just starting out in the field, it gives them a sense of belonging, a sense of ownership, and it really it gives them an opportunity to keep their skills fresher because they're working with newer therapists that may have had some more updated training on different areas. And so it makes it a way of, with a student program, you can not only recruit well with a student program, but also it helps retain those experienced people. We also want to look at networking with other rehabilitation professionals. A perfect example is our program directors, rehab directors within our rehab units. They have other rehab directors to talk with, different hospitals, different hospital systems, but they're all part of the Signet Health family, and we foster that networking between the professionals so that they're not alone out there in doing the job that they do. They do have a village of other professionals that are doing the same type of job that they can speak with, talk with, problem solve with. As I had someone tell me today, one of my directors, she goes, I really like not having to call you every single time. I like being able to call other people that are doing the same job that I'm doing and problem solve with them as well. Then we also, from another way of for retention, I was speaking earlier about education. With Signet Health, we can provide certified registered rehabilitation nurse specialization accreditation, or CRRN, as well as other therapy specializations. We do have a program for training for the CRRN currently in-house within Signet that's available to the facilities that we work with. And we're also able to look at therapy specializations and utilizing outside resources in order to be able to identify the best certification specializations that a specific person needs within a hospital. So if your hospital is well known for treating stroke patients and you have an acute rehabilitation unit, stroke specialization for your therapist would be something that you would look at. Not only helps the program, but also helps the employee, because the employee is learning more and happier in the job that they're doing. I said this before, culture matters. It always matters. It's very important to look at how the employees are treated within the hospital, but also in how they feel within the ethics of the organization, and feel comfortable with the way that an organization works. This ties back into communication. Also, with Signet Health being a family-owned company, I will say from personal experience, there is a true difference in a way that when there's a mission-driven process, I feel it as an employee, and it makes me proud to be a part of the organization I work with as well, and therefore I want to stay with this organization as well. Ownership of success is also very important. In this area, having specific things for specific people within a rehab unit, rehab hospital to do, regardless of where they are within the organizational chart, giving ownership of other processes or projects gives employees that ownership of the success of that program.
Okay, next slide. You know, we talked earlier about 70% approximately of clients, patients we serve in these programs are from acute med-surg hospitals that are already within your walls. The other 20 to 30% are external, and it could be short-term acute care hospitals, stacks without ARUs, inpatient acute rehab units. It could be different senior community service groups, primary care, some SNFs, long-term care, LTACs. So there's a variety of places our clinical liaisons for a program would reach out to try to grow and service more clients in the community that are not within the hospital's walls. Next slide. So we have a couple different clients that we service. One are new startups. The other are existing ARUs. Paul, you may want to comment on a couple of the things you see on existing ARUs that were brought in to help.
Absolutely. In doing a review of an existing acute rehab unit, there are some areas that we like to target questions for and seek some information. And we need to look at, what are the goals of that existing ARU and what we want to try and do. So we'll specifically look at what is the volume of that unit and what are the opportunities to increase that volume. We can look at what that 60-40 percentage area is for the rehab criteria, and if there's some room for that other category, and they're not really, if some places not really utilizing that that aspect there may be a possibility to bring in some other non-traditional acute rehab patients to that unit. We also have to look at what are the discharge patterns of a hospital. Is there a tendency to send everyone to a SNF because it's easier? It's quicker. They can get approval for it quicker. Those are some areas that create barriers to us being able to bring a patient in the ARU if we're not getting the referral from within the hospital itself. That could also come from the therapist. Are the therapists making the decision from the acute side of who should be seen for, or who would be appropriate for acute rehab, or is there an ability for the hospitalist, if the physiatrist can go and do be referred to go take a look at that patient. We also will look at the quality program data through UDS. Most of the rehab units and hospitals use the UDS system for this. And so there are some direct areas that relate to the quality programs within the CMS Medicare system. And this data from the UDS system will give us a very clear indication of where a hospital is based on their quality ratings compared to other facilities, as well as compared to rehab hospitals versus a rehab unit. So we can look at, are there opportunities within that quality data program? Are we collecting the data correctly, getting the right data, and inputting that and submitting the correct data so that we are getting paid for what we're already doing, and so that we make sure that we identify the great quality of a program and also identify areas where we may need to work on that quality. We'll analyze the therapy productivity and compliance and making sure that that 3 hours of therapy is being done. That is the big criteria for an inpatient rehab setting, is that they're receiving that 3 hours of therapy 5 days out of 7 days. And so we'll analyze that. And then we'll establish external referral development and with community marketing and with a program for appropriate admissions. This means getting outside of the hospital, having our program director or liaison getting outside of the hospital and working on those referrals from the community.
Okay, next slide. We just have a couple more slides. We'll be finishing up here. So Signet can certainly, if you do not have a unit, analyze your data. It's very important to analyze the internal demand to see if it justifies considering offering inpatient acute rehab. We're very conservative, realistic about potential external, but this is something we do all the time. And we have a very 20-plus-year-old tested model that we analyze data and then look backwards to see what the programs actually ran. Next. Yeah, just briefly, I'll hit this real quick, Paul. We can look at your physical plant to see if it does make sense to add a new program. So that's something we do all the time. We come on site. Next slide, the financials. And I just want to touch very briefly, we would do a financial analysis for you, but you can have a small 10-bed rehab unit that runs three patients, and it breaks even on a cash flow EBITDA basis. And certainly we have a number of hospitals that can run 5 or 6 patients and do fairly well, contribution EBITDA wise, however you want to format it. And then if you're in the potential to run 7 to 10 patients, the annual EBITDA is probably about $1 million. And if you're in double-digit range, a teen, it's probably $2 million. So these are, once again, patients you have in your hospital that you could treat today, not have to send them out, and they contribute financially. Next slide. And this just says we, could do the analysis for you. There's no charge to Vizient members to do this. Next slide. And one of the other things Signet can offer are to put up a building. If the volume is such that you need your own rehab building, a pavilion or a freestanding, we can finance it up to 100%. Of course, that has to be approved by Signet's board, the Browder family. But this is something we can offer. We're not a publicly traded company. We don't have to ask private equity, can we get the money? Or, we can try to fund this internally. And we can also, if it's with a behavioral health project, we have some of those that we're working on right now, where we put up a new building. Part of the building is behavioral health, part is rehab, and it can make it more economical to do a project. And then you could have, move your psych rehab out of the hospital and have more space for med surge. I think it's the last slide. This is just a picture of what a building could look like. And clearly we have spent a lot of energy and money to have a standard footprint that is an option for a joint venture building, and certainly could talk to you if you have enough utilization. And I think the last slide's actually just my contact, and if there are any questions. So we appreciate the time here today to talk about Signet's rehab services.
We do have a few questions for y'all that that we'd like some folks have asked that we'd like to answer. What are some of the additional key recruitment strategies that Signet utilizes? I believe this would be for you, Ann.
Yes, great question. I know I listed a few of them earlier. What we try to do is we try to customize our ads and list what's in it for the candidates. Even something as simple as putting the sign-on bonus or flexibility in hours at the very top is very eye-catching. We also make it very easy for folks to apply. We have our career page, web job boards, but we also do text messaging. And the newest thing we have been using is QR codes for applicants, make it very easy to apply right into our applicant tracking system. Other strategies I touched on, we do partner with associations, healthcare associations, national ones, and where we can, we try to exhibit at their conferences to meet and mingle with their members, send out e-blasts to their members, different things like that. And then also with the colleges and universities, we have great clinical folks on our team that can offer presentations and provide CEUs. So those are some of the things that we've been doing lately for just capturing that great candidate. It is our job to identify top talent for all of our programs across the United States.
Okay.
Thank you.
I've got another question here. What does it look like, or rather, can Signet come on site, and when they're assessing existing inpatient acute rehabilitation programs, how can you determine exactly how to enhance that performance and grow the service line? I believe the question is there a charge for this? I believe is that free, Pat?
I'll start it, but yeah, there's no charge for that if it's a 1 or 2 day assessment. And usually what we can do in 2 days, certainly meet with the majority of stakeholders. Often it's 15 to 20 people. The hospital said, for this rehab service, you need to meet with the medical director. You need to meet with hospital case management. You need to meet with the VP of quality. Of course, I want you to meet with the CFO. They're going to tell you what's going on financially. And, you could meet with the nurse manager on the program. Some do not have clinical liaisons doing external, so we have to meet with hospital-wide marketing. But it's not cookie cutter. We want to go in and we meet one-on-one with these people, half hour to an hour interview, and just talk and what's working, what could you do better? And every time I come out of there, there's 4 or 5 just things that hit you in the head that if you do these, it'll help. And of course, it's about execution. Paul, comments on this?
We would want to really make sure that we're speaking with from an enhancement standpoint with the people that are currently working in that unit. Clinically, what are the programs that they currently are doing? Any specialty programs? And what are the goals of the actual employees of that unit? Where do they see the growth of that unit coming from, or how it can be better there? So, but then we're going to dig deep into actual data within the quality program within the UDS system or the CMS quality program, and look at the data of what's going on in that program from a documentation standpoint, and look for those opportunities of what we can help that unit improve upon based on what they're already doing, and looking at that data and doing a deep dive and combining that with interviews with the staff that have been providing that information.
Yeah, that's a good point, because we try to look at the data before we go in, which can lead to informative questions of the staff. Thanks, Paul.
Absolutely, yes.
Kind of a follow-up to that. Got a question of how quickly, or rather how fast, can you start a new ARU after an agreement and partnership is formed?
Yeah, this depends on the physical plant build out, but if the physical plant was ready, we can get started 90 to 120 days post-contract signing on a new ARU. The thing that I will mention, of course, we've done it less than that. Signet, in its 23 history, with many, many startups tied to the Medicare fiscal year, has never missed a startup. So we've been able to rally the resources quickly to get it started. But usually it's a prolonged process to decide to bring us in, and we're not under a 30-day deadline to meet it. but 90 to 120 days, we can have things in place, policy and procedures, line up things to get it accredited. And on a new startup, contractually, if we fail the survey, the contract terminates. So we do have an incentive to make sure the program opens successfully.
Great. I've got two questions here that are fairly related. How does an ARU with Signet Health compete against an existing IRF, or rather inpatient rehabilitation facilities, or an SNF, skilled nursing facilities, particularly with the SNF being half the cost of ARUs?
Yeah, so that's looking at the skilled nursing programs and the comparison of how do we compete against those, I believe is what I'm understanding from that question. An acute rehab unit can compete very well against those local SNFs, skilled nursing facilities. And it's because there is a focus on rehabilitation care in the acute rehabilitation unit. Whereas in a skilled nursing facility, especially with some of the changes in their, the dynamics of their payment system, the focus is no longer on that therapy piece of it. An acute rehab unit provides therapy services for a minimum of 3 hours a day, 5 days a week. That's a minimum. In a skilled nursing facility, the amount of time of therapy can vary dramatically, and you often will hear complaints of that a family member hasn't been evaluated by therapy in 3 or 4 days because they came in on the weekend and there was no one there to do that. In a rehabilitation program, you're looking at 6 to 7 days of therapy being provided on that unit per week, and therefore patients, one of their priorities for their stay is to be receiving that therapy service. And so in looking at being able to show the data to not only referral sources and physicians, but showing that patients have a shorter length of stay in the acute rehab than they will in a skilled nursing, and they're returning home at a 65 to 75% rate based on national averages. So we really, from a marketing perspective, will push all of those areas out through communication and internal and external communication where that hospital resides.
Great. Got one last question here. What were the changes that occurred on October 1st with CMS on rehab?
I've got that one. This is Paul. Yes, so October 1st is the official changeover date. Everyone who's worked with within a CMS provider status knows that October 1st is when things always typically change. New rules get implemented, and the changes will take place on that October 1st date. For acute rehabilitation, one of the largest changes that happened this year on October 1st was that the IRF-PI, which is the document that has to be submitted to CMS on every patient, it changed from what they called IRF-PI 3.0 to IRF-PI 4.0. There were substantial number of changes in the data that has to be collected on both admission and discharge of patients. And so that would be one of the biggest changes that took place. One of the areas that we do education on extensively with our PPS coordinators and make sure that they are on top of this, they're ready for the change, and that so that any discharges after October 1st are being, they're sending in the correct information to CMS and therefore ensuring payment for that patient. If they don't include the right information, they can put payment at jeopardy. And so it's an important piece of the education that we do with Signet Health in order to make sure that the folks that are responsible for this understand, know it, and are able to do it when it's time to be able to do it.
Okay, well, that's all the questions we got. Pat, did you want to say anything before we wrap up?
Yes, I really appreciate Vizient's partnership with us and for all their members. And clearly, this will be posted as a video on the Signet website, I believe on Vizient website. If anyone sees this and was not able to attend and would want to talk to our business development people, questions about this, or talk to Paul, please reach out to me and we can put you in touch, not just with business development, but clinical and operational people that can answer some of your questions.